With that, we come to another area which everybody is very familiar with, amniotic membrane transplantation. Dr. Lomi is going to again encapsulate in practical terms what are the applications and give you practical tips as to what is currently known as what are the best scenarios and what are the best results that you can achieve by this treatment.
Very good afternoon to you all. At the outset, I would like to thank my teacher, Professor Radhika Tandon, and the AIOC organizing committee for giving me this opportunity and the platform to present this lecture. I'll be speaking on empty membrane transplantations. So I have no financial or conflict of interest any in this presentation. So the learning objective of this presentation will be a little bit of genesis of empty membrane transplantation, the biological properties, the preparation and storage of the of empty membrane, the risk application methods, the indication and recent advances. So a little bit about the history background of empty membrane. It was first recorded use in 1910 by Davis by using skin transplantations, and was popularized. First ocular application was used by D. Roth in 1940. So there was a gap of around 60 years between where the empty membrane was used again by Batley for congenital defect. Most probably because of this risk of transmission of infection, or maybe the better preservative media was not available during that time. And the later it was popularized by Kim and San in 1995 for the ocular surface reconstruction. So the biological properties of empty membrane is that it is the innermost layer of the placenta, as we all know, and basically it has three layers: the epithelial layer, the basement layer, and the stroma. And the basement layer is most tensile, and then layer where it give the whole integrity of this empty membrane, and it has got this collagen type 4, 5, 6, 7, and fibronectin and laminin, and the stroma part, which produces the various growth factor like fibroblasts, hepatocyte, and transforming growth factors, which stimulates the epithelialization and modulation, further cause proliferation and differentiation of stromal fibroblasts. And also it suppresses various inflammatory cytokines like interleukin 1A, interleukin 1-2, interleukin 8, and also have the risk factors like protease growth inhibitor factors and all. So the mechanism of action is it acts as a pro-epithelialization, anti-inflammatory, anti-neovascular, anti-fibrotic, and also a very substrate for cell growth. So it has all these factors has helped that the transfer of this from the wound, the biological tissue to the wound. So here's a short video how empty membrane is prepared and is cryopreserved. So basically, that empty membrane is taken out from the plant cesarean section while collaborating with the gynecology, and you have a proper eye bank setup. The patient, the pregnant mother is well screened of all serological tests is done, all HIV, VDL, all hepatitis virus has been screened. And this is followed by the removal of the placenta, and then it's bring to this to the eye bank in the lamellar hood area through the very aseptic measures. It is cleaned by balanced salt solution, and also with some cocktail of antibiotics. So once it is bluntly dissected, you can see the thin membrane of the empty membrane is peeled off, and it's cleaned well with and all the debris and all the clothing has been removed. After that, it is placed on the nitrocellulose paper and on the various and cut in various shape according to the utilization of the endpoint. So after that, the tissue is transferred to the media. This is the Dulbegos Eagle's eye medium, along with this glycerol in a concentration of 50% in 1:1 ratio. And they have cocktails of antibiotics there like streptomycin, penicillin, amikacin, and also amphotericin B also. So after preparing this one, they store in this media, and then the tissue bottle is kept in a deep refrigerator, cryo freeze in -80°C. And after that 3 months time, again the serological test has been done for the mother to rule out any serological positive test, which we have done it so that to rule out any window period time also. So after that, it is dispensed for the use to the user end. So various application methods has been explained. One is the inlay transplantation, where the amniotic membrane is placed with the epithelial cells upward. So basically, it is used as a dressing, temporary dressing, wound dressing, and it's covered or also used as a single layer or multi-layered to fill the scaffoldings wherever in the ocular surface is there. And only is like with epithelial cells downward to protect the defect area. And a sandwich is most commonly used where the scaffolding area is filled with this empty membrane and then followed by the inlays, the onlay transplantation. So various indication has been is there for the use of this empty membrane, like most commonly chemical or thermal burns, the persistent corneal epithelial defects, some corneal ulcers, reconstruction of conjunctival ocular surface, various diseases like Stevens-Johnson syndrome or ocular pemphigoids, and also some bullous keratopathy. So here's the case of acute chemical burns where empty membrane transplant has been used and has shown a very good result in 1 month time. So studies at RP centers also, which is published in BGO by Professor Radhika ma'am and his group and her groups. So it has shown that in grade 4 and grade 5 of Duas classification, where it has shown a very remarkable results in terms of the rate of epithelial healing time, which is significantly better as compared with the standard medical therapy alone. There's another studies which shows the efficacy to compare between umbilical cord serum drops and then empty membrane transplantation. And in grade 4, 3, 4, and 5 Duas class presentations, which also shows that the mean complete epithelializations between the cord serum group and the empty membrane transplant group are comparable. However, in terms of the corneal clarity, better pain control and avoidance, umbilical cord serum has better effects. However, there is no difference in the symbiotic formation in all these three groups. This case of neurotrophic ulcer refractory to the normal convention treatments. So here the sandwich technique has been applied, empty membrane has been applied, and we'll see the good results, and the patient is now ready for the corneal transplantations. Another case of corneal keloid here after excision, there's a good result following use of empty membrane. In case of persistent epithelial defect, yeah, you can use for this empty membrane both inlays and onlays, and we see a very good results in a month time. In case of bullous keratopathy, where you are not intended for any dissect or demake because of the poor visual prognosis, and here you can use empty membrane to relieve the pain or also to maintain the integrity of the ocular surface. Another important utility is in ocular surface tumors, where it's been shown to have a very good response after, and then less recurrence is seen in case of using empty membrane. Here, in case of this congenital melanoma case, where we have done excision, and then after that with cryo and empty membrane transplantation, we still have very good results. So far, there's no recurrences with it. And then even in case of ocular surface composite neoplasia, you can see a very good results with post-excision followed by an AMG. A case of giant OSSN where like more than 6 clock hours has been involved by this nodular ulcerative OSSN. Here we have done the excision and the post-op at 2 months. We have shown a very good results. Here, I want to emphasize again the utility of empty membrane. Again, since we all know the component of empty membranes, they have various factors: anti-inflammatory factors, anti-fibrotic factors, angiogenesis factors. Apart from that, the transparency of the empty membrane, it helps to see if there is any residual or recurrence tumor are there, which can be assessed in the follow-up time also. So another important utility can be in the case of contractile socket, where it can be used as a furnace formation, and we can give a very good cosmesis following utility of this empty membrane. In case of small corneal perforation, less than 6 millimeter, you can use empty membrane to seal the perforation, where empty membrane is cut in very small pieces, where you can use multi-layered of empty membrane, and then you can glue using a fibrin glue, or you can use a suture and place over it, and followed by the onlays of empty membranes, which can be sutured or you can glue it again. So it has been shown to be useful in case of especially aqueous deficient disorders, and we can usually avoid that when there is infective infection is still there. Next is the simple limbal epithelial transplantations, which we know that is first described by Dr. Virendra Sangwan in 2012, where after this his after describing this slide, there are many papers which have validated and its efficacy in restoring the ocular surface, renewing the corneal epithelium, and also avoiding the reconsolidation of the cornea. So here you see a donor clear limbal area. That donor limbal cells has been harvested around 2 into 4 millimeter thickness, and then recipient bed, all the panels and has been removed and clear off. All the debris have to be clear off, and followed by you can place a onlay over it, empty membrane, and it is sutured and followed by a glue is applied, and then after that, this donor harvested limbal stem cell can be cut in very small pieces and away from 2 mm away from this limbal area, and avoiding the visual axis, you can glue it and followed by BCL applications. So here's one case of limbal stem cell transplant has been done where post-chemical injury again here after SLED, we can see a very good result here. One case of SLED which I have done here, in this case there was a bleeding, the hematoma formation was there. So in this case, either you can wash it, if it's not coming out, it's not clear enough, they can wash it with, make a small hole over it and make it wash it, or otherwise with medication with time it also started resolving. And we see in this case at 4 months time, it's a very good results following this SLED also. Another is cultivated limbal epithelial transplantation, which is introduced by Dr. Pellegrini and group in 1997, where it's utilized especially in case of bilateral limbal stem cell deficiency, or where only 1 to 2 mm of the healthy limbal is harvested and is expanded in the laboratory. So, but the drawback is that you need a sophisticated laboratory for it, and also it's a two-stage procedures. So here's one case where post-chemical injury, this clad has been done, and it is shown a very good, remarkable results. So some of the recent advances of utility of empty membrane is empty membrane extrait drops and an empty membrane extrait. So it retains the growth factor activity. So it enhances the wound healings and by decreasing this, by preventing this fibrosis, and also inhibit the scarring formations, and also it promotes the wound healing and regenerations. So there are various studies which have shown the efficacy of this empty membrane extrait eye drop, but still it is not FDA approved as of now. Next is the non-surgical applicable of empty membrane Procera. It is a cryopreserved empty membrane which FDA approved in 2003, and the Schaeffer Sang company have offered this dispensing of this product. The device can be inserted as an office base or in daycare procedure itself, and the advantage of it is it has both the biological and technological benefit of empty membrane. It's as a small 2 ring. Inner ring is around 16 millimeter. The outer ring is around 21 millimeter. They can directly place over it. Or many people have now innovated by using the small Ral's tube of the infant Ral's tube. Also, you can place it, or you can use contact lens over it also. So to conclude, the structural integrity, transparency, and elasticity of the empty membrane makes it currently the most widely acceptable tissue replacement for ocular surface reconstructions. And the characteristic properties of biological properties of empty membrane is help at every stage of the wound healing. And the key of successful empty membrane transplant is a meticulous selection of both the donor and the recipient, and also maintain a high standard of quality assurance. The future innovation is on Procera and empty membrane extrait shows that there's even more good to be derived from the amnion for the eye. And then I would like to acknowledge Professor Radhika ma'am and Dr. Vanati for giving me some of these patients' pictures and also the videos, and Professor Sujata Mohanty from our stem cell facility for providing and helping us in this journey, and Professor Bhavnachala ma'am for all the support and help, and my SRs and SRs for their contribution indeed. Thank you all for your kind attention.
Thank you very much, Dr. Lomi. It was a very nice, comprehensive explanation of the basic physiology and the practical applications of amniotic membrane transplantation. Thank you so